Hello everyone, my name is Barbara Kindle and I am glad you could join me today and I'm very excited to show you my presentation on my DMP project titled Trigger Point Pain Improvements Through Adjunct Massage. And before we go on any further, I wanted to discuss a little bit about how or why I thought this presentation would or this project would be helpful to the patients at our clinic. I've been a nurse practitioner for about 2.5 years, and I do trigger point injections at the clinic where I work and where this project took place. And I'm also a massage therapist, and I've been a massage therapist for 11 years. And I know massage can help patients that are in pain as well as trigger point injections. So I thought combining the two careers and adding massage to after trigger point injections could benefit the patients at our clinic tremendously. The next slide here discusses my committee members that have been extremely helpful and supportive throughout this project. My DMP chair, Dr. Jessica Bland, my community member, Dr. Mayor Green, and my second reader, Dr. Snell. We all experience pain during our lifetime. Musculoskeletal and myofascial pain affect 80% of the population. Trigger point injections is one treatment that can address musculoskeletal and myofascial pain as well as trigger points. Massage therapy is another intervention that can help with muscle pain and uses various techniques depending on the patient's conditions and what their needs are. There are several aims to implement this quality improvement project and answer the question in adult patients, does adding massage therapy after a trigger point injection decrease pain scores than just a trigger point injection alone? The first aim is to evaluate the effectiveness of massage after giving a trigger point injection. The second aim is to evaluate the pain scores after implementing the massage. And the last aim is to implement the massage after every trigger point injection, making this a standard of practice at the clinic. In this slide, we will discuss the literature review. After conducting the literature review, there were 11 articles that were chosen. The common themes that were seen throughout this literature review were chronic pain and trigger point injections, alternative pain management through using therapeutic massage, and improved patient outcomes to decrease pain. So let's go into a little bit more detail now about these themes. First is chronic pain and trigger point injections. Of those that experience myofascial pain, there is a prevalence rate of 46%, with the cause of chronic pain being those hyperirritable knots, which are also called trigger points. The second theme is alternative pain management using therapeutic massage. Massage is the manipulation of soft tissue to decrease pain. Therapeutic massage is one of the oldest modalities used today. The third theme seen is patient outcomes to decrease pain. There are physiological effects to massage that decrease pain through relaxation and the release of endorphins that affect the body both mentally and physically. In this slide, we'll discuss the strengths and the weaknesses of these literature reviews. All studies were randomized controlled trials. Randomized controlled trials are strong studies that have a treatment implemented has a control group and a researcher that randomly assigns actual groups and intervention group. Another strength was the numeric pain scores. This tool is valid and reliable and is most widely used to assess and reassess pain. This tool rates pain 0 to 10, with 0 being no pain and 10 being the worst possible pain. The last strength is that all the articles, all 11 of them, had a conflict of interest statement and an IRB approval. The weakness noted is convenience sampling. Convenience sampling is when a participant is chosen because they are ready to participate. Another weakness seen in 2 of the studies is that one study was done in one city and another done in another setting. There were several gaps seen in the articles reviewed. 7 of the articles did not have ethnicity noted of the participants. One study had only female participants, and another study only had male participants. 2 of the studies did not have a placebo group, and a placebo group is a group that received a fake intervention. Another gap noted is that there were no data collected for any treatment that the participant may have received outside of the study. Five of the articles had a low sample size, which is a limitation. A small sample size may limit one from knowing how it may affect a larger group or population. 2 of the studies, as previously noted, only had males and females. This is a limitation because it cannot be generalized to the other gender. A risk of bias is another limitation. In the Beathers et al. 2021 study, the risk of bias was due to subjective outcomes because when a participant is part of a study, you cannot really control activities done outside of the study. The theoretical framework used for this scholarly project was Kolkaba's comfort theory. This theory has 3 states and 4 contexts. The 3 states are relief, ease, transcendence. The 4 contexts are physical, psycho-spiritual, social, and environment. When we are in pain, for whatever reason it may be, our comfort suffers, and our pain affects our mental health, our relationships with others, and the environment we are in. All the states and the context within Kolkaba's comfort theory attack pain and allow us to bring our patient back to a more functional state. This theory impacted the work of this project because we addressed the patient's pain in order to give them relief and, as mentioned before, bring them back to a more functional and comfortable state. The data collection seen here was designed by this researcher. The data collection was designed to collect the minimum amount of data needed for the goals of this project. The first chart seen here was used in the chart review, and the second was seen with the massage intervention. The only difference in the charts is the massage intervention column in the second chart. All the data was locked in a cabinet, in a locked office, and on a password-protected computer. The numeric pain rating scale is an excellent tool, valid, and has a reliability in assessing and reassessing pain. This tool is widely used in healthcare and is why it was chosen to assess and reassess pain scores in this project. The participants in this study were adult patients, both male and female, aged 18 to 75, when the nurse practitioner's schedule, who were coming in to have their pain evaluated, and those found to have trigger points. In the in-person portion, there were 78% female and 22% male participants. 2 participants were aged 18 to 30. 13 participants were 31 to 51, and 8 participants were aged 52 to 75. In the chart review portion of this project had 41 patients with the same criteria as the in-person portion. The chart review portion was from July 2022 through December 2022, and this included 61 participants, female, and 39 male participants. The age range included 7 participants aged 18 to 30, 26 were aged 31 to 51, and 8 were aged 52 to 75. The data collected for this project was analyzed using the Wilcoxon Signed Ranks test, which is a non-parametric test used to determine if there is a statistical difference between 2 values. The values in this project were the pain scores before and after the trigger point injection and after the massage intervention. This type of test also decreases any outliers in the data. Slides 13 through 18 will discuss the results found in this project. This slide here shows what the pain scores were after the massage intervention was implemented. There were 23 participants. As you see in this slide, the total number comes to 24. The total pain scores came to 24 because one participant had 2 different pain scores. 17 participants had pain scores that did decrease after the massage intervention was implemented. 0 pain scores increased after the massage intervention, and 7 pain scores were equal to that of the trigger after the trigger point injection. This slide shows the statistically significant change with the z-score as -3.778 and the p-value of less than 0.001 after adding the massage intervention. This slide is what the pain scores were before and after the trigger point injection. As in slide 13, one of the participants had 2 different pain scores, which brought the total number of pain scores to 24, with 23 participants. 18 pain scores decreased after the trigger point injection. 1 pain score increased after the trigger point injection, and 5 pain scores were equal to before and after the injection. This slide shows the statistically significant change with the z-score as -3.745 and the p-value of less than 0.001 before and after the trigger point injection. This slide is the results of the chart review. 41 charts were reviewed looking at the pain scores before and after the trigger point injection. 37 participants had a decrease in pain after the trigger point injection. 0 pain scores did not increase after the trigger point injection, and 4 pain scores were equal before and after the trigger point injection. This slide demonstrates the statistically significant change with the z-score as -5.348 and the p-value of less than 0.001 for before and after the trigger point injections during the chart review. The limitations that were seen in this project was a low sample size. When meeting with the statistician, it was determined that the sample size of 53 participants would be needed. The sample size in this project was low due to patients having fear of needles, and some did not meet the age criteria for this project. The results of this project answered the question that it set out to answer, that adding massage after a trigger point injection would decrease pain scores than just giving a trigger point injection alone. The data that was analyzed using the Wilcoxon-signed ranks test demonstrated a statistically significant change with a p-value of less than 0.001. There were many strengths found during this project. All participants were very happy to be a part of this project and to potentially help other patients that come after them. There was no missing data because all participants had pain scores that were documented. There were no unintended consequences, and there were no out-of-pocket costs because the researcher worked where the project took place, and all supplies were readily available. There were many implications for practicing during this project. The first is that all results from this project could benefit other patients at this clinic, as well as other clinics that do the same type of injection. The results could also benefit other providers if they were to implement the same massage after giving their trigger point injections. The last implication for this practice is that the findings could develop into a standard of practice. In conclusion, this project and its findings demonstrated how adding massage after a trigger point injection can decrease pain scores. The results demonstrated a statistically significant decrease in the chart review before and after the trigger point injections, as well as the massage intervention. What I would recommend would be to complete this study on a larger sample size, different age populations such as under 18 or over the age of 75, because any age group could develop trigger points. When implementing a quality improvement project, it is important to think about the sustainability of that project. The plan is to continue asking pain scores before and after all injections and after the massage intervention. If other providers join the practice, the findings of this project will be discussed with them and how implementing or adding massage after the trigger point injection. This will become a standard of practice. Communicating the results of this project is important as well. The plan for dissemination is to share with the clinic owners, participants of the study, future patients, and staff at the clinic. I've learned a wealth of information throughout my DMP program. I have gained knowledge that I can use to help my work environment, patients, and the surrounding community. All of my instructors throughout this program and my DMP chair have been the best and very supportive. The DMP program has made a huge impact that I will use what I have learned from instructors and other classmates for the rest of my career. I will pause here for any questions you may have. Below is my contact information should you have any questions later. I want to thank you for listening to my presentation, and I hope that you have a chance to read my paper. The last few slides are the references used in this presentation.